All right, good morning. Is this working? All right, so good to see you all. Thank you all for being here. And welcome to the Unconference. I know it seems structured, and traditional conferences will give the impression that our ideas and innovations are neatly packaged, but as you can tell from today, that's not always true. And change is messy and unstructured. And we want to create a forum for the Unconference. And so there's a couple rules about the Unconference that I think are important. One, it'll start when it starts, and it'll end when it ends. So as you can tell, we had a little bit of changes today, which is okay. It is a participant-driven model that started back in 2010. And although we have an agenda with somewhat directional, the conference is going to ebb and flow based on you. So we sent out a survey. We heard from many of you about topics to cover, things that you were interested in hearing about. And many of our speakers today, and certainly our panelists, are going to address some of those questions. And so really, we want this day to be determined by you. So even though we have a structure, we can change it. So we want to hear from you. So I told you rule one is it'll start and it'll end when it'll end, and it will start when it will start. And so we're going to start now, but we may start and stop. We also, whoever shows up are the right people. So thank you for showing up. You are the right people to be here today. Rule two, whatever happens is the only thing that could have happened. So, right? In Hebrew, Segal taught me zemayish, and that means what happens is the only thing that could have happened in a way. It just is what it is, right? And then rule three, I told you, is when it starts, it's the right time. And the fourth and final rule is when it's over, it is over, and we'll let you know. Although much of the day will be guided by you and your engagement, we hope to frame some of the discussion. So let me kind of lay out our framework today. I think all of you have an agenda. Unfortunately, I do need to share Segal, who is from Hadassah Medical Center and lives in Israel, was unable to join us this morning. I have had the opportunity to spend the last 48 hours with her, and what an incredible experience and an incredible woman. We did get her on video this morning to leave you with a little inspiration. But I just wanted to take a moment of silence to think about our community and humans that are suffering. And I know whether you have folks there or not, I think we're all deeply affected by the war and conflict that's occurring because we're humans. And Peter's going to talk to us a little bit about love, and I think we need love now more than ever. So really appreciate you being here, Peter. And Balaji will give you a proper introduction, but we're excited to hear you talk. And Agility we've partnered with, and Bowler College of Business. So thank you very much to Alad and his team, as well as Balaji and the Agility team. Balaji and his team from Agility are going to lead us through a design section. So we'll have a working lunch. So after we hear from Peter, we then have a panelist as well of incredible chief nurse executives from the Cleveland Clinic and UH that are going to talk about the learning mindset. Things, especially as we're going into major healthcare workforce challenges, I think and how they've been innovative both pre and post-COVID. And then we'll hear lastly, then we have a business panelist after lunch in the design session where we're going to hear from Alad from the Bowler College of Business, as well as David Sylvan from UH Ventures and Chief Strategy Officer, as well as Julie Jacona, who's the Chief Strategy Officer at Metro Health. So that should be an awesome panel where they're going to discuss how they turn opportunities into reality. So that should be exciting. And then lastly, Balaji and I are going to close. We're going to address a lot of the questions. When we have lunch today, we're going to have Post-it notes and a whiteboard that we want to post any of your questions and last-minute ideas, as that fireside chat will be really a dialogue between all of us to end the day. And then we'll have an opportunity to network one more time before we leave this afternoon. And we will hear from our president, Al Mikiak. But the most important rule of the day is to have fun, enjoy each other, and really to foster a community of innovation between academia, clinicians, and technology, because together we can tackle hard stuff. And so my message for the day is to innovate with passion, heal with purpose, and together we can reshape healthcare's future. So without further ado, I will introduce you to Balaji to say a few words and then bring Peter up to talk.
Good morning, everybody. I'm Balaji. Thanks for being here. Like Melissa said, before I do the introduction, I do want to play a little clip from Seagal this morning. I don't know if you guys knew this. She was standing here, right in this room, only 2 hours ago, and we could get her a flight back home at 10:50. So we had to do the right thing. But she did leave you guys with a message.
Okay. Hey everyone, I'm Seagal, and I'm a nurse, an entrepreneur, and I wanted so much to come and share with you my journey from nurse to entrepreneurs. And my journey now is back home to Israel. And my only inspirational message at this moment is that we will overcome, we will stand up. It will take time. It will cause us pain, sorrow, blood, and tears, but we will make it. And I want to thank Melissa and Bellagio and Elad and Lisa and all of you for this such a warm hospitality and for this invitation. I was so excited and thrilled to come here and to share it with you. And I'm so sorry that it happened like this. And I wish you good luck. And I wish you a good journey in your life. And just do that. Thank you so much.
War changes everything, and an Unconference is no exception, right? That's why we are here. We will be watching her, make sure that she goes home safe, and her family is safe as well. As we contemplate war and peace, our next speaker has a very important message for all of us. And it is my pleasure to introduce Dr. Peter Pronovost. He's world-renowned patient safety champion. He's an innovator, critical care physician, prolific researcher. I think, Peter, the last count, I think you're a little over 1,000 published peer-reviewed paper published. You're an entrepreneur yourself, you're an innovator, investor, and you're certainly a global thought leader. And his scientific work, I think we all know about Checklist, as being credited with saving thousands of human lives over the time, and that has gotten him accolades, one of which is being named 100 most influential people in the world by Times Magazine. He's also received MacArthur Foundation Genius Grant and is regularly recognized for other, I think recognized as the most influential executive and a physician executive in healthcare. He's Cleveland's own. He's with University Hospital and recently led the efforts at University Hospital that won them the American Hospital Association's Quest for Quality Award. It's a prestigious honor for UH, and I also think for the Cleveland community. He is also named the Veal Distinguished Chair in Leadership and Clinical Transformation in 2023. Peter, I have about 3 more pages worth of this, but I think the community knows you. So it's an Unconference. Without further delay, Peter, thank you so much for being here.
Thank you. Thanks, Balaji, and thanks, Dr. Cole, for having me here at this great conference. That I think that what's going on in the world makes my remarks even more timely. The biggest problem we face in the world is our inability to solve complex problems collaboratively. Just look in healthcare. 1 in 4 patients are harmed. 1 in 2 suffer because they don't know how to care for themselves when they're discharged. All but the rich suffer enormous waits and suffering to get access to care. Labor productivity is negative. Costs are increasing. Payments are decreasing. Bankruptcy is increasing. 50% of health systems have negative margins. And despite spending enormously, God-popping sums on technology, the only thing that we have to show for across the country is increased billing and burnouts. Literally no other signal has gotten better. As a result, the survival of not-for-profit health systems, like the clinic, like Metro, like UH, that serve our communities, are threatened. Yet it doesn't need to be that way. You see, here's the thing. The inability to solve complex problems is simply due to the lack of love. Now, that may sound esoteric, so let me first explain what love means to me. Love is an energy that uplifts and connects us all. It's a force innately in each one of us. It means that we all matter, that we are born worthy of respect, that we have agency, that we have our voices heard. Love sees the wisdom and beauty in every person and invites their ideas to the table, regardless of your pedigree. Love is the absence of separation. Yet too often, we're separated. We look down on other people. We think we're smarter than them, so we deploy top-down command and control solutions that never work. We say that if you don't have the right degree or the right title, or you don't dress the right way, or you stutter, or your skin's not the right color, or you don't have the correct ideas, then your voice counts less, to such an extent that some people believe that they're less worthy. We discount ideas, diminish the ability to debate for fear of feeling contempt or being canceled. We destroy progress and innovation, and in doing so, we demean, demoralize, and decrease energy. We destroy our ability to solve problems and diminish value for all. When we lead with love, the opposite happens. We believe people are innately good. We respect, uplift, and unleash. We feel we matter. That is, that we feel we are valued and add value, and thus support dialogue and encourage the free flow of ideas without fear. We seek good ideas and effective solutions from wherever and whomever they emerge. We focus on what works rather than who brings forth the idea. Love is strong enough for you to dislike someone's ideas, yet see their common humanity. When you leverage the power of love within and between people, you solve problems better, faster, cheaper. Learning and innovation flourish. Now, let me be clear. This is not some touchy-feely, feel-good philosophy. This is about accountability. For sure, love feels more joyful, yet love is the path to results. That's the leadership that the world needs. It's the leadership that healthcare needs. And my story is how I came to realize that. My origin story is also the story of my worldview and my philosophy in healthcare and my philosophy on life. I was born the son of 2 orphans, yet we created a super strong family. I felt I mattered, so I could question and discuss problems. My voice was heard. My parents empowered me, and I felt significant, secure, and loved. Our family was small, yet devoted. My interest in safety was forged from healthcare's failings. At the young age of 50, my father died after having been misdiagnosed. He could have been saved by a bone marrow transplant, but by the time we got the diagnosis correct, it was too late. And I remember carrying his crumbling 80-pound body up to his bedroom with him writhing in pain. He suffered for a week, and during that time, a desire to improve healthcare was etched in my soul. When I was applying for med school, I experienced a lack of love. Johns Hopkins was my top choice, and when interviewing, an older male physician said to me, "Why should we admit you to Hopkins when you didn't go to an Ivy League college?" Now, I wasn't very academic in high school. I spent time in sports in socializing and far too much in detention. I went to Fairfield University, go Jesuits, and yet reading Plato my freshman year in college was my phoenix. It ignited my intellectual curiosity. So I responded to his question by saying, do you have evidence that students from Ivy League colleges are better physicians? My GPA is a 4.0, and you may discount that because it's not an Ivy League school. But my MCAT scores are the top 99.9% in the country. So if you believe in objective tests, then I meet your standards. If you believe in pedigree and privilege over performance, then reject me. You have to decide what you believe. Well, I was accepted and went on to be one of the most top published and rewarded physicians in that very laudable school's history. And just prior to my 4th year of med school in August, my father died, and I was not going to be able to continue because I couldn't get loans that late to pay the bills, and we didn't have the money. And that older white physician waived my tuition. I will never forget his love. After I graduated, I did a residency and fellowship in critical care and a PhD in the School of Public Health, and I was publishing, but I wasn't excited. I didn't have my purpose. My dad's experience made me want to improve things. That desire ignited when Josie King died. Josie was an adorable 18-month-old girl who looked hauntingly like my daughter. They were born days apart. And Josie died on my birthday from a central line infection that led to sepsis and teamwork errors, all of it preventable. At the time, these infections killed more people than breast or prostate cancer, yet we just accepted them as the cost of doing business. We accepted that when you care for sick people, little girls will die. Her mom, Sorrel, asked me if I could tell her that no other children would die the way Josie did. And I had this moral moment. I wanted to say yes and tell her all the things we were doing to prevent harm like any executive would. But I couldn't. Our infection rates were sky high, and they were sky high in the country. So I did the thing that love calls you to do. I told the truth. I said, no, I can't tell you today, but I will be able to one day soon. These experiences coalesced to help me find my purpose, to leverage the power of love within and between people to solve problems that makes the world a better place. Love means seeing that innate goodness in people and believing everybody matters. Love provides a home and a house to debate, just like the home my parents provided me. When we reduce people to their ideas, we stop seeing them as human and destroy our ability to innovate. That experience with Josie's mom sent me on a journey of rigor and accountability that became a career in keeping patients safer, improving value, and creating a new category of research called quality improvement or implementation science. That launched an effort to eliminate infections at Johns Hopkins, then in the state of Michigan, and then state by state across the US, and then in 8 other countries. Now, this was frightening. There was no playbook for how to eliminate harm in a country. We had to persuade 5 federal agencies, the AHA, state health departments, state hospital associations, and scores of health systems in every state to work together when they had never before. At the time, HHS measured these infections 5 different ways. What worked was aligning around a common purpose, agreeing on a common goal, and connecting and unleashing all powers to innovate towards that goal. The lessons I learned through that experience is that love not only allows you to stand in your bright light, it also puts you under the spotlight. Love demands accountability. Accountability that seeks others' success rather than to punish, that seeks to support and inspire rather than to judge. The science of quality improvement at the time wasn't a science at all. Indeed, the common mantra was that the data are for quality improvement, not research, as if the data know the difference. My view is that if I was going to look Sorrel in the eye and tell her publicly that little girls are less likely to die, I needed robust data to say that confidently. Yet at the time, no quality improvement study had collected robust data. Indeed, they averaged, and still do, 80% missing data. We changed that. We require that participating health systems commit to less than 10% missing data, or they would not be allowed to participate. No one dropped out, and 80% of hospitals went a year without an infection. My roles at Johns Hopkins grew, and I was a professor in the schools of medicine, nursing, public health, business, and engineering. I ran the ICUs and was the SVP for system quality and value. And then I founded the Armstrong Institute, which is a research group that brought 18 different disciplines from every school in the university to do transdisciplinary research to solve problems. Just before COVID, we left for Cleveland with my wife, Dr. Marlene Miller, who's the chair of pediatrics in Rainbow and also a distinguished professor at Case. I had the goal of trying to create a model for a health system for value. Our thesis was really simple. That is, we said if we use this framework of living and leading with love, we can transform care at UH and spread it. It's truly been the most amazing time of my life, and I'm so grateful for all my UH colleagues. Our model is really, really simple. We call it Believe, Belong, Build, and it's based on what's been barriers to transformation. All employees must believe that their job is to improve value and feel empowered to do so, and to have a clear and inspiring vision of the future that is better than yesterday because of their efforts and aligned with their values. We need structures and cultures so people feel they belong to a learning community, a network that supports the free flow of ideas from anywhere so that we could allow innovation to occur faster and cheaper. And we need to build robust management systems and accountability systems because they're often, or more commonly, universally lacking in healthcare. We apply these to keep people healthy at home instead of healing in hospital, and we made visible and eliminated defects in value. Now, you may think this is the soft stuff, yet it's the essential stuff if you want transformational change. Fear may get you short-term, small-scale results, not broad, deep, lasting transformation. But here's the thing. You don't have to take my word for it. Just look at the data. We reduced the annual Medicare cost by 33% over 4 years. If the country did that, we would solve our healthcare problems. We saved Medicare over $100 million over 4 years, and just this year received $38 million in shared savings for improved quality. We reduced surgical length of stay from 6.2 days to 2.1 days. We reduced sepsis mortality by 70%, reduced A1C for 1,000 diabetic patients by 1.5 points. We reduced the average cost for complex Medicaid patients by $10,000 a year, but more importantly, tripled their sense of well-being and their quality of life. We reduced sentinel events by 90%. We reduced our system length of stay and all met our targets for the first time in our history. And these are just a sample of examples of scores of projects that all had breathtaking results when this model was used. It's literally almost foolproof. Yet the patients are still suffering, and our healthcare is still riddled with defects, so our journey to zero harm is far from over. Josie's mom had asked me if other children would be less likely to die. At first, we couldn't tell her. Now we can. We achieved an 80% reduction in those infections across the U.S. and a 70% reduction in 8 other countries, though with COVID, the rates have gone up recently. But the culture changes were just as robust, dramatic, and enduring. Sorrel and I talked to hundreds of hospitals around the world and to scores of media outlets. That ignited a movement of patients whose loved ones had been harmed, forgiving and partnering and loving with health systems to make things better. We built teamwork and collaboration in clinical teams to ensure that doctors used a safety checklist and partnered with nurses for accountability. We transparently shared results to hold health system leaders accountable. But the deeper lesson we learned is that it wasn't only the checklist that's magic. It was the belief system changing. Clinicians began to believe that it's not inevitable that little girls are going to die. They believe now in zero harm. And more importantly, they believe that they could work collaboratively to achieve that. They found and felt the power of love. You feel that same energy of zero harm and love when you walk around UH. I'd say, Melissa, we feel it in your Unconference here. when you feel it when you walk on the hospital wards, in our team meetings, and in our Tuesday clinical transformation call that many of you join. You see, when you live and lead with love, everything feels different. Problem seems less daunting, and it's the most precious and powerful gift. Our results achieved recognition, as from Balaji mentioned, the AHA Award. 6 reviewers visited UH for 3 days, and when they left, they said, "We felt that transformational energy of love that you shared at the opening comments. We experienced when we walked out in the wards and talked to your staff, and we saw people making personal I will statements. My only question is, how do you spread this? Because you have a responsibility to." And now we're spreading this approach to other health systems through a new initiative called Valens. That's a partnership with 15 large health systems who are all trying to innovate and solve healthcare's biggest problems with the best technologies. The biggest lie, though, that we've accepted in healthcare is that we label harm as inevitable rather than preventable. We shrug our shoulders and say, things happen, and when you care for sick people, little girls will die, fathers are going to die. I refuse to believe that. These are not unsolvable problems, not in healthcare, not in the world. That capability is in every one of us if we just live and lead in love. Now, don't get overwhelmed by how daunting or nebulous this sounds. Simply start by reflecting on a time that you felt you mattered, that you were empowered and connected with other people to solve problems. That playful energy, that sense that anything is possible, is something most of us have experienced, and we can create it. Love is lived in micro moments, these little moments of positive connection. So here are a few of my favorites. I'd ask you to think about where you make micro moments. Listen to a colleague who is suffering. Innovate with a colleague and create uplifting energy. Declare a goal of zero harm when working with a team. Pause for a moment when walking into a patient room to create empathy and think, just like me, the person's a mom, a dad, suffering. Feel the energy when we debate ideas and we then create a common purpose and path. Ask what you learned and how could you support when a team falls short of its goals. Assume positive intent when you disagree with someone. Thank our caregivers by name for improving value when you pass them. Smile respectfully at that homeless person. And when you're feeling overwhelmed that you've been asked with an insurmountable goal like eliminating infections in the U.S., take comfort in knowing that leading doesn't mean you have all the answers. It simply means that you have the courage to ask the questions, the clarity to convene the right people, and the commitment to see the task through. The answers to problem dwell with the people. Believe in them. Love's other name is understanding. Without understanding, we cannot love. The most powerful micro moment of love you can create is to be humble, curious, and compassionate enough to listen deeply to the people around you, to learn from them, and then to thank them for helping you make the world better. So to all of you who live and lead with love every day and make Cleveland and our communities better, I thank you, and it's an honor to collaborate with many of you. I want to share one final micro moment with you. My mom has advanced dementia and doesn't recognize me. She's in an assisted living facility in Connecticut, and yet recently we had this beautiful micro moment when she did, just fleetingly. We were holding each other, and she looked me in my eyes, and we connected deeply in our souls. She started smiling deeply, and then teared up tears of joy. She grabbed me tight, and then it went away. The moment was fleeting, but that power of love is awe-inspiring. We face many challenges in healthcare in the world, and they seem that they're only growing daily. The power of love is that we all matter and we're connected, even with all of our messiness and majesty. And we can leverage that power within and between us to make the world a better place. All of us have experienced that pain of feeling unloved and the power when we do feel loved. Imagine how much better the world would be if more of us live and lead with love every day. We need you, every one of you, to live and lead this way. Our patients need you. Healthcare needs you. The world needs you. To start this, someone has to believe in people and say, this is a problem that's part of my purpose. It's within my power to solve it, and then convene a group to go make it happen. That someone, I think, is each of you. So please go live and lead with love. Thank you. Yeah.
All right. So I'm going to bring around a microphone, but opening it up for questions.
Can you guys hear me okay? We did a survey online to ask people for what they thought about this conference. And one of the topics, the questions that came through the online section was, I want to just read this out and get you. It's not going to work. Love seems to be a strong message when people are cared for by the nurses, people that are there providing care. How do you translate that feeling of love to the second order of magnitude, people that are not directly in patient care, but still have an impact on patient health? What is your message for them?
Yeah, so it's the beauty of that we're all connected. I think for those further away, we too often don't connect what they do to a purpose, right? And so they feel, and I often hear the phrase, but Peter, I'm just a data analyst. I'm just a coder, right? I'm just an accountant. And I think in healthcare, we do a poor job of reframing that and saying, well, no, let me share with you what you do. Like I can tell you, every week I have a meeting with my assistant, Miracle. It's just about 10 minutes. And I say to her, because you coordinated and orchestrated all the stuff that I had to do, I want to share with you the impact that you had this week, right? And she's like, wow, that's really cool. I had no idea that I really matter. And I said, well, everybody matters. How else do you think we're going to get all this stuff done if every link in the chain doesn't work? And so I think we just have to be more mindful of making sure that, all of the people on the teams know. I mean, we're putting in Epic right now, and sharing stories of success or improved care with the Epic team where the analysts are really powerful, them to connect to their purpose and just inspires them to work harder. Melissa, since it's an unconference, I'm going to sit and do a fireside chat.
Great. Hi, I'm Anne Marie Lyons. I'm from UPMC in Pittsburgh and an alum here too. So your Connect to Purpose resonates with us, the UPMC crowd, because this is something we do at UPMC. So we actually share our purpose. And so people like me, I'm an administrator. I'm not bedside. But I can still share my experiences. And so we just met last week. We meet quarterly as leaders, about 2,000 of us. And we always start each morning of the session with a Connect to Purpose. And it really brings us back to why we're there. And it's funny because I think everyone in the room probably has a connection, a father, your own personal story, your own experiences. Sometimes they leave a room of 2,000 people all crying, but that's okay. And I'm just sharing and recognizing what you say, but we make it intentional. And the Friday session, our takeaways were that in every meeting, we are to have a connect to purpose. Somebody is to connect to the purpose for why they're there. So it's very powerful. So
Thank you. And again, this isn't squishy stuff. I mean, there's pretty compelling literature in the business literature that if an organization has a purpose, although that's not enough, and supervisor level know what behaviors they do to connect to purpose, you are literally 4 times more effective, right? So all of those and those of you who are on clinical transformation know all this purpose gets translated into very specific projects at a unit level. What are their behaviors to drive it? And it's just so powerful. So thank you for sharing.
Good morning. I'm Michelle Herford. I'm the System Chief Nurse Executive at University Hospitals Health System, and I have the pleasure of working with Dr. Peter Pronovost. There are many things that Peter referenced, and I'm going to ask a question so that he can share further how he has engaged all levels of our organization in demonstrating that they matter. So one exercise was around creating I will statements. So Peter, can you share with this audience what happened during that time?
Yeah, so, and let me just take 1 second to go back to give you the evidence for believe, belong, build. When we were, after reduced infections, I had this hunch that it wasn't a checklist, that there was something deeper that going on. So we partnered with some anthropologists and sociologists and interviewed clinicians. And what they said was, Peter, what got to zero was changing our beliefs. We used to say, these are inevitable, and I'm just a fill in the blank, a nurse and attending. And there's pretty good literature that if people don't feel self-efficacy, as you all know, or don't feel that it's their problem, nothing's going to happen. The build is just the innovation 101. I mean, the belonging. If you don't have a structure to allow the free flow of ideas, you're never going to innovate, because that's where every innovation comes from the world, and a culture that makes it safe to speak up. And then the management system. So we believe this deeply, but our organization, like many, often the most lowest paid people who now actually spend some of the most time with patients aren't invited to the table. Our transporters, our EVS workers, they have a role, but we don't even think of them as being part of the team. And we knew we would never achieve our goals if they weren't. And so we started this campaign that asked every working role, what do you need to stop believing and start believing for you to see values your job and that you are powerful to do it, right? And we had them create I will statements that we then took pictures of. We had zero harm them. I don't have slides, but I'm happy to share with them. And we, every unit or every team throughout 23 hospitals made them. I mean, much of it was driven by our nurse managers and CNOs, but I'll share with you some powerful messages. Amongst EVS workers, transport workers, nutritionists, the pictures that we took, every one of them were Black, right? And there may be in those roles, Michelle, I don't know, 95% people of color, and every one of their messages was essentially feeling the lack of love. They all said something to the extent of, I'm going to stop believing that my voice doesn't matter. I'm going to stop believing I'm not part of the care team. I'm going to stop believing that I can't make change and start believing that my voice matters, that I'm going to drive change, that I'm an important part of the care team. And when you talk to them, it was literally like a transformative mindset. When I say you can feel the energy, because it really is that palpable, and we reinforce it, but they see themselves now as being an integral part of the care team. So when we then speak to our transport people about the ability to create empathy or release suffering when you walk in that room, or when you're going to clean the room and you're an EVS worker, honoring that space as a patient's sacred space, it's their home. And so to be gentle and respectful with their things as you move along. And so it's been an amazing, powerful, and to be frank, it wasn't just EVS workers. Many of our nurses and our doctors felt my voice isn't heard. I mean, and you know, it's interesting, and I'd love to ask the audience a question. I don't know where we became afraid to connect to purpose, because I mean, it's scary to do that. I can tell you, like, speaking about love as an academic, like, first people thought you're like a wacko, right? Or this is all touchy-feely, but I hope you can see, like, it's pretty hardcore science and accountability. And when you make or give space to be vulnerable, it's really powerful. People connect it. But I think so often we think if we're not rigorous, if we don't only focus on finance, then we're somehow softer or not great leaders or innovators, as opposed to seeing, you know, as you can probably tell, I believe deeply, purpose precedes profits. And if you, and there's compelling evidence that if you put profits first, you're going to burn an organization out, create fear, and you won't achieve performance. So I think we all have to get comfortable sharing that way and intentionally invite everyone to the table. Thank you, Michelle. Michelle's my partner in crime on these things. We'll sit in meetings texting each other and nudging as we try to echo these messages.
Hi. I agree with the things that you're saying, and I was fortunate enough to work in the not-for-profit world. So I got to see a lot of this. But my question is, how did you convince the money people in the organizations, the finance departments, the people who have to deal with the insurance companies making the agreements or fighting the bills, the people who have to collect the bills from people who do or don't want to pay or are not able to pay? How did you convince them that this was going to make their bottom line better as well?
Yeah, great, really insightful question. And let me just talk about two convincings. The first was when we started this journey, convincing our board and our executives to focus on value. So before we even talked about losing money, because even though we have a large ACO, 95% of our revenue is still fee-for-service. And so when we were RVU focused, making budget focused, so at a board meeting talking about value, I put 2 chairs in the front of the room. And I said to our board member, you all serve different roles. You're a board member at UH, but most of you run businesses or you pay taxes at the least. So in the chair on the right, I want you to think like a UH board that you normally talk. And in the board chair on the left, I want you to think that you're paying for healthcare, that you're responsible for the budget. And I said, let me share with you a story of Helen, true story, who was admitted to our hospital 15 times in the last year with heart failure, 14 times to the ED. And every time she showed up, the part worked perfectly. She got what I call reactive and transactional care. The ED did what they need to do, the cardiologist, but we missed that Helen's admissions were completely driven by an anxiety that nobody diagnosed. She got anxious and get short of breath and then would come in. And we missed that she skipped most of her appointments because her daughter died of an overdose and she was caring for a disabled granddaughter and didn't have transportation or respite care because CMS doesn't pay for respite care. So she skipped her appointments. And I said to the board, in our P&Ls, you count every one of those 15 admissions as a win, right? It's no different than you save someone doing cardiac surgery. We're paid for them. They're invisible, right? But they're defects in value, right? They're not serving our communities. They're not serving Helen. And they're not serving our care team because they're demoralized knowing this is the kind of care that is being provided. So the question for you is, do you want to be the board member who sits in a fee-for-service mindset and says these are all good because they add to our bottom line? Or do you want to take our responsibility to serve the community because communities didn't fund not-for-profit healthcare to fill hospitals. They funded us to meet the health needs of their communities. And those 15 admissions are all waste. By the way, they cost us $1.2 million. We're not really much reimbursed for these, and Helen's in personal bankruptcy. So that got like this, okay, I get it. How do we do it? So we're not irresponsible. I'll share with you, because last year we lost $250 million in operating income, and we've turned it around pretty strategically this year, but it was very intentional of living with love. What do I mean by that? Well, we know we have to engage everyone in length of stay, so I mentioned our surgical length of stay. That length of stay from 6 to 2 days, about a 70% reduction in length of stay is as if we built 70% more beds. We have demand for our services, but they didn't cost me anything to build, so I can refill them. We also know that we lose $50 million a year on general medical patients, 60% of them who don't need to be in the hospital and would get better cared for if they're home. But we didn't have an ecosystem to do that. So we pulled this transformation team and set up teams to get people from the ED to specialty care the next day, to get teleservices, a whole variety of levers of same-day access to primary care, to specialty care, to get people discharged early, to do post-discharge TCM and med-rec, so we reduce readmission, like a bunch of different levers, but readmissions go from 26 to 4%, and then we have some what we call leakage. So our ACO, about 65 to 70% of people get care at UH, but the rest go to others. So we orchestrated those other patients who were going outside of our service who needed care to come back in. And so it's a model that allows us to win in fee-for-service. It allows us to win in the ACO because all those admissions are reducing total cost of care, but most importantly, to meet our community's needs for accessing great care, because they shouldn't be in the hospital in the first place, right? And so it's not at all naive, it's very strategic, but thinking creatively and innovatively of, it's not either or, how do we meet a community's needs and win in both fee-for-service and value? So bottom line is it's working. Other questions?
Hi, thanks. I'm Catherine Han-O. I'm the director of the Counseling Center here at John Carroll. Also building out with Melissa a resilience program for the nursing students. As you think about burnout and resilience of healthcare staffing the last few years, I'm also imagining all the changes you're talking about kind of hitting the front line as potentially more work, or worry that this is going to burn us out further. What are your thoughts about how your philosophy addresses resilience and burnout, and how do you reach those frontline staff who might be sort of on the dregs of their energy at this point?
Yeah, super, super important question, and thank you. With our burnout rates amongst all care roles just at unacceptable levels. So a couple thoughts. There's pretty compelling data that burnt out employees can't address new projects. But when you peel that onion, that's because the way we do improvement or projects in healthcare is almost always top-down, command and control, treat workers like monkeys, right? You will use this checklist. We don't say why or what's it for. We don't allow innovation. And what our approach does two things. The building resiliency is really important in burnout, but it doesn't substitute for leaders' responsibility to make work easier, right? And in many health systems, work sucks. I mean, our health system works like with a clunky EMR, and it's like we do a lot of things that wasting staff's time, and we haven't put enough focus on that. So let me give you an example that Michelle and I led with a couple of her nurse leaders to address this burnout. We asked, what things do we do that are a waste of your time? And specifically, what policies do we have that the burden exceeds the benefits? We did this brainstorming innovation session. They identified about 60 policies that collectively wasted 50% of their time. 50% of their time. And at first, I mean, this was like, give me a minute to go into this because it was like magical thing. First, we started in there, and there was apathy in the room. And this was maybe 55 nurse managers. And they opened up saying, you know, Peter, we have this policy group that meets every month, but we don't have any agenda items for policies that are burdensome or that need to change. And I'm like, really? Why do you think that is? Like, I don't know, we just never did anything in here. We haven't come up with any. So I said, okay, like, let's put ourselves in a new space. Imagine you are powerful to change anything, right? You don't need to get permission, like, just ideate. And then the energy just snowballed, and they, like, you know, started literally in just an hour listing either policies or technologies that can reduce their burden. And then we revised those, which was the easy part, but we found they're embedded in 1,200 order sets. So then we had to go and change 1,200 order sets, but it freed up immense amount of time. And it's that, like, as leaders, we have a responsibility to improve the working environment because, like, yes, I need to do self-care, but self-care is only going to go so far. If I'm running 100 miles or my productivity is 120%, it's a fool's game if you think that's going to solve, you know, all these needs. And the same with teamwork. There's great data that creating strong teamwork. And again, those are the conditions that leaders and managers foster this kind of, you know, again, I call it love, but it's basically respecting people for the roles that they need. What we've seen is like the exact opposite, is when we approach this with units, not by telling them what the solution is, but by engaging them and helping understand why. So we'll say, we had 5 falls the last week or the last month on your unit, and we had some people with aspiration. We think if we ambulate people, we might be able to prevent that. How are we doing on ambulation, right? And, well, not really good, Peter. We're busy, we don't have time. And I said, okay, well, we have some tools to help you. And we now made a dashboard. We partnered with therapy, and we can give feedback. What do you think if we try to get 70% of our patients ambulated twice a day, right? And they're like, oh my God, yes, we can do this. And so I think when you approach this by unleashing and inspiring people's creativity and innovation rather than command and control, it's the antidote to burnout. I mean, people really, really like it. And I'll share with you, when I was at Hopkins, I published with a number of our bioethics people and a number of nurse researchers. And at the time, we had unit-based safety teams called CUSP, and many of you may have heard about those. And the health system did a number of things to reducing burnout, recognition programs, all the things that you would normally do. When they did the research, both qualitative and quantitative, the only thing that reduced burnout was these local safety teams, because they connected them to purpose and they were inspiring them. And so I think if done well, these could really help burnout. But by no means am I saying that. I mean, Michelle and I, every day, we're thinking about how do we design care systems that are less burdensome on our caregivers. Let me add one thing for you, because I know there's many nurse leaders in here, that this has been like the most profound way. Balaji mentioned we have this VEAL initiative where we're looking to solve healthcare's biggest problems with technology. One of the main ones we're starting on now is labor productivity. And as you probably know, labor productivity in the past has been nurses care for more patients and run faster without taking any work per patient away, right? I mean, it's the most stupid way of thinking of productivity you could imagine. So we developed this framework with Michelle that says we kind of systematically ask 4 questions. What could I stop doing? Because that's the highest value if there's no work. What could we automate with AI or other technologies? What could we either do remotely or with a less costly staff? And what must stay sacred at the bedside, right? And staff resonate with that approach, right? Because it honors their wisdom. And we don't tell them what those solutions are. We just say, let's systematically walk through this rather than kind of being whack-a-mole of thinking, this computer vision is going to solve this or remote this is going to solve that, but being more holistic.
Thank you. Joachim Voss, Case Western Reserve University. I'm the PhD program director in the School of Nursing. Peter Bierhaus just published that in 2021, 40% of nurses have left the profession after 4 years of graduation. And schools of nursing are asked to take more and more students, but we will never fill that bathtub if we have that much of an outflow. And so I was wondering what your discussions are at UH to address this issue with schools of nursing, because if there's any way of dealing with this, it can be solved in combination with the clinical centers in their preparation for the clinical reality.
Yeah, thank you for asking that question. I'll say a few comments, but then I'll have Michelle, who's the experts in this. This nurse crisis that we have is a perfect example of the inability to solve problems, complex problems collectively. And no one group is going to solve this. The schools aren't solving this alone. We aren't solving this alone. And so we have to think more creatively. Michelle will say the solution, but just as a systems thinker, one of the problems that I see that is so driving this is the schools don't have enough clinical instructors, so people are graduating with not a lot of practical experience. We then put them on wards where, as Michelle has schooled me, they may be comfortable caring for 2 patients, and they're caring for 6, and they're scared and frightened. They're worried about their license. They often do hurt people because they're in poorly designed systems, And we wonder why we have these kind of, turnover rates that we have. And so we need to think innovatively. I think we probably need some models where that we think of more apprenticeship things where people get much more on-the-ground training with our clinical instructors leading, but that we could either get different incentive models, much like a residency is supported, so that a new nurse, there's support for a health system to keep their ratios 1-2 or 1-3 until they get comfortable, just like, we get support for a resident. So I don't know the solutions, but I do know that we have a major problem, and our current way of thinking about it is like Einstein's definition of insanity. We're not getting. I think HRSA has a role in looking at alternative payment models for keeping ratios at a safe level. But Michelle, you live this every day.
We do not have the solution. I will say that. There are multiple things to do. And I would also say that my colleague, Meredith Fox, who will join me on a panel probably in a few minutes, I don't want to steal our thunder, if you will, so we'll take that time to really dive into this quite deeply.
I will just add, starting a new school of nursing here at John Carroll and having partners like Dr. Pronovost, Michelle, Meredith from the Cleveland Clinic, Metro Health, UH, having these anchoring institutions, we are beginning to think outside the box and how we need to do this differently, and how we prepare our healthcare team of the future, both from a resiliency perspective, I think, as Catherine mentioned, but also how we collaborate and partner to provide a supportive environment as well as a learning mindset in our students, and have the resources for them to be successful, not to turn over in 4 years.
And Michelle, I 100% expect the outcome of your panel is that you have a solution solved at the end of it. So I look forward to hearing it at the end of the day.
Sounds like that's love with accountability, Michelle.
That's exactly right.
Any other George?
Melissa cringes when I get the microphone.
Not true.
I'll be cool. George Lewandowski. I work with the pre-meds here now. I'm a redirected GYN oncologist. Oh. I wrote down the question. I almost didn't ask it, but I will. How do you deal with the senior physician who says, why are you asking me to change and do more while paying me the same or less?
Yeah, so great question. Matter of fact, we're having this discussion every day. I don't know if you saw the recent CMS data, and if not, I can send it around. An AMA just did a report. Since 2001, Medicare payments to physicians have gone down 21%. Every payer is reducing their payment. And I'm not making a value judgment. CMS is clearly making a value judgment that U.S. physicians are paid too damn much. And we're paid a lot more than, and again, this is their mindset, right? And so in the past, how did we absorb that shortfall? Health systems picked it up, right? It's probably one of the main reasons why many physicians left independent practice and joined large health systems. I mean, there was a whole bunch of reasons we didn't want a billing. The number one reason was they were losing money and they saw the trains going down, and like, because you can't get productivity that much to make up for these big reductions in payments. So I think we need to have a house for a mindful conversation because this is the headwinds that we're facing. Payments for physicians are going down, and they're going down across the country. The only way you can keep your salary is if you grow productivity. I mean, it's economics 101. That's how GDP grows. And so there are ways we could use technology to grow productivity, and we need to. But we are getting to a point where we have to have a conversation to say that how realistic is that to continue. That's going to be a really dicey time, because if UH were the first to have this conversation, we would lose a lot of docs to the clinic and Metro, right? And indeed, what we have right now in many communities like ours for rare specialists like GYN is an arms race, right? We pluck them from each other hospital, and they negotiate higher salaries, and it's just not, it's not a sustainable model when health systems have negative margins now, right? And when we had FAT, you could float some, you can still support, I mean, we still support our physicians a great deal, but we need our physicians. And how do we, begin to balance that? The fear that I have is what we will see is those physicians that are least reimbursed are the same ones that hospitals lose more money on. And so there's like behavioral health access, really hard in our community. Why? Because you lose money on an inpatient. OB access is going down, right? You lose a lot of money and very, very risky. Medicaid patients, like more complex patients that are more vulnerable, you lose a ton of money. And so there's a lot of, challenges. As an executive, one of the things that we're doing to help support our physicians is, across the country, the only payer group that is growing is government payers. Medicare, depending on what state you're in, Medicaid might be going up or down. And particularly Medicare Advantage, which has a much higher denial rate, so we get paid much less. Right now, an average hospital loses about 15% per patient on Medicare, right? So that math doesn't work. I mean, if concretely in our numbers, our Medicare reimburses us about $15,000 per discharge. We were at about $18,000 cost to care for these patients. We're doing one of our major strategic goals is to get to be profitable on Medicare level payments. We're down now to about 16.1, maybe 16,000. So we took $2K off per discharge, but we're lazily focusing on how do we get that cost of discharge down so we have, a 3% margin on Medicare level payments, because without a margin, we can't grow programs and support this work. But there's a whole lot of innovation that I hope you're all going to solve to help us figure out how, to get there. And I mentioned to date, the innovation hasn't borne fruit in healthcare. I mean, as I said, we're the only industry that spends heavily on technology and has negative labor productivity. And our view of productivity is, faster. So I think the discussions we have with our doctors is saying, it's not that we love you any less, but this is like just the reality that we face. The payers don't value your service as much, and they think we're overpaid. I'm not saying that we do, but that's the payers. And so we have to work together. And what we've done is engage them to say, help us get our cost structures down so that we can drive value. So what does that mean? Like, we have a huge effort amongst our surgeons to get supply costs down in the OR, right? And before they didn't act like an owner, so they would open up anything. I'm, the God, I want to have it just in case. And now we're saying, hey, be part of the solution with us, right? If you want to keep your salaries, then you have to work with us to get these other waste out of the system. And there's plenty of waste. So long response to, I think, a conversation that needs to happen across America.
We've got time for one more. Jody?
Maybe this one's bridging your initial comments to your last couple of answers. So when you think about love, and you're leading with love and what we're all doing, and then you think about innovation, right, and tech and AI, to me, I struggle with the idea of the loss of the relationship when we introduce some of the platforms we have. So I'm curious your thoughts on when we innovate and do things, asynchronous monitoring as an example, what does that affect on that patient relationship, and how does that fit into good, bad?
Yeah, really, really insightful question. And so I would begin with, let me my premise. Why has innovation in health delivery not worked, right? So let me just frame this for you. If you look at innovation in drug and devices and just look at vaccines, diagnostics, or therapeutics, crazy, crazy innovation. Healthcare, negative labor productivity. 1 in 4 patients harmed. 1 in 3 say they're disrespected. And so I think I have some very clear thesis that we're trying to solve in view of why that is. The first one is we don't focus on big problems, right? We focus on a shiny widget that is frankly a waste of much of my time to work because the problem's not big enough to get executive to get the time. Two is we have horrible usability because we don't honor the wisdom of the frontline clinician or patients, right? Epic's the perfect example. You will use my workflow, right? As opposed, like, what human-centered design would ever do that, as opposed to saying, no, we're gonna support how work can be done more efficiently. Unlike drugs and devices, we have almost no rigorous evaluation. That drugs and devices do RCTs. Innovation in health delivery is the app maker saying, look how much money I saved you. And I'm like, oh, but was there a control group? No. How many patients did you study? Oh, 5. And how long was it? Oh, a week. Really? And you want me to believe those claims? And then there's not aligned incentives. So I think as we're solving problems, the experience of patients has to be, so we're launching like this effort for labor productivity, an effort to do remote discharge. The patient's experience will be an outcome that we'll manage to, or that we'll see. But that's a great example where we could impose the technology and say, hey, this is how you're going to do this. But we did some brainstorming with some of our nurses, and besides the admission or discharge, one of the nurses said, hey, if I have a camera, why can't I do that double check for a medicine with a remote nurse? Because it's really risky when I walk to get a separate nurse to go distract them, from what they're doing, because it imparts risk, and then come and walk over, and they're not really paying attention because they're thinking about the patient, and do that. And so that kind of brainstorming, they've probably identified like 10 things like that for the same technology, no more cost, but other ways to add value that were all driven by honoring their wisdom. And so I think we just need to realize that the tech's a tool to serve patients and our caregivers. All right.
Thank you very much, Peter. Let's give him a round of applause. As a gift, we feel very fortunate to have all of our speakers today, and thank you for getting us on the right track. It was a rough morning. So each of our speakers, and we have some to give out to the audience, is What Do You Do with an Idea? It's a children's book. But thank you for inspiring us and leading us with love and telling us how we can do something with an idea and make a tremendous impact. So thank you.